Thanks for the opportunity to talk to you all today. I was thinking about coming up here and trying to set the stage for those of you that haven't seen me talk before. I can be a little bit contrarian to some of the themes. I don't think I'll be too contrarian to some of the points you've already heard this morning. Someone was encouraging me maybe to draw the analogy to politics, but I couldn't figure out what group of large organizations I would suggest should be dismantled, and I wasn't sure that I would come across as being particularly strong if I came up here and said that I'm trying to build a better health care. So I'm just going to focus on what I do. I will not try to make health care great again, and instead I'm going to jump in and talk about something that hopefully is at least a part of your thinking. If it hasn't been so far, maybe this morning we can prompt some dialogue around it, around creating a learning healthcare system. Micah was nice enough to invite me back this year. I gave a talk last year at Medical Informatics World, and it was a really nice experience for me. And one of the things that I put forward in that talk was this question around, are you on a path for creating a learning health system? And so what I'm going to do today is kind of build off of that question. And I think one of the things that a lot of people talked about at that time was really not necessarily about whether they were on the path of a learning health system or not, but how would you even know if you're on a path for a learning health system? We use this term a lot, learning health system, and we talk about translational medicine and translational science as a key underpinning of moving forward with a more cost-effective and clinically effective health delivery model. And yet it's really difficult to even define sometimes what we mean when we say a learning health system. So I am a technologist and a strategist by training, and I focus on this kind of intersection between clinical, business, and technology, and the role that innovation plays in that. And one of the things that is usually involved in that process is a lot of design-oriented thinking, trying to think about how do you move from a collection of requirements or a collection of needs into something that is executable and buildable and implementable by people. So if you go back and look at some of the early Institute of Medicine publications around what a learning health system is, I put some of the quotes over here, but really there's a variety of features that start popping out. Even though there isn't an explicit definition, there's a variety of features that begin to come forward that characterize what we think a learning health system might look like. And so my goal today is to try and link some of these capabilities to a development and a learning model that our organizations collectively can kind of go through. And for the sake of time, I'm going to try to breeze through a lot of this. I'm going to give you guys a lot of content today, but I'm not going to sit here and read slides. And so, so I'll try to breeze through them quickly, but we can talk at the end about any particular elements that jump out at you. The features for me that jump out as we start thinking about creating learning health systems and how innovation might translate into creating a learning health operating model are here on the right, and they include things like this emphasis of generating more data, and not just data in the traditional context that we think of EMR data, but both process and outcomes data. So there's this bias around creating data and an expectation, as you see down a little further in the features, that there's a different type of insight generator being created here, something that's a lot more sophisticated than what we were talking about earlier today when Nick was talking about EMRs being particularly good at reporting stable things, but not necessarily being good for innovation. This is where this begins to kind of come into play. And some of the other features on this list really kind of run a little bit counter to the way that we're currently investing in population health programs. So for example, this last one, this idea of being able to make decisions that are more personalized and tailored to the level of an individual patient, that's not something that's commonly being characterized in population health programs today, where we're trying to develop policies and mechanisms and resource models that treat large groups of patients consistently, which is also a good thing, but is not necessarily geared towards this idea of personalization. So like I said, part of my job is to try to take some of these weak signals and begin to put some structure around them. And so, I wanted to give you an idea for how some of that design might start to look. We could spend all day in here designing what a healthcare system that learns looks like. And so this is at a really high level, but I thought it would be useful at least to talk about some structure and some components around this just to get your mind going. So one of the first things that we need to think about when we're talking about learning, and I'll show you a little bit more about this later, is that learning is highly contextual. And so it's not going to be sufficient for us to just collect a large bunch of data and put it in repositories and throw analytic tools around it unless we're doing a better job of characterizing what that data actually means. What is it? In other words, knowing that the EMR says that the heart rate of a patient is 73 is an interesting data point, but if I don't know if that was before, during, or after a treadmill test, not really helpful in me understanding how to interpret that information, right? So we need to be doing a much better job of contextualizing what data means, the workflow that's associated with it. And I would argue that that actually is probably one of the first steps that we need to do, because if we get that wrong, everything that happens after that is much more difficult. Moving on from that, we then need to be thinking about, well, how do we instrument some of this? If we're really serious about creating a learning health system, we need to be making sure that we're collecting the data that's going to be critical for us to be learning from. Certainly our investments in EMRs are helping us in collecting data in a more routine way, and certainly gives us a lot of capabilities that we did not have when we were doing the paper charts. But it's also true that EMRs in and of themselves are better at collecting data than generating it. They're really good at documenting, but there's a whole strategy that we need in place around how do we instrument both clinical and process data collection that would support this kind of learning model. Then comes my favorite part, the analysis part, where we're actually going to be focusing on creating insights. And I won't bore you with all of my typical soapboxes around analytics, other than just to say the world of innovation here is particularly ripe, and we're going to spend a little bit more time talking about what that looks like in a minute. And then at the top of this is this idea of then shifting from everything being about evidence-based practice to beginning to shift about practice-based evidence. This idea of bringing together the world of clinical research, but also the world of real-world observations, things that we can see happening in the delivery of healthcare today that should be informing how we make changes to improve the delivery of healthcare tomorrow. So that's a lot of design concepts in a really short period of time, and I apologize in blowing through this quickly, but I just wanted to set the stage for it, because as we want to start talking about creating a learning health system, we need to have some kind of framework for thinking about how that environment needs to look. Now, as was commented on earlier, Nick, I loved your comments on EMRs and what they're good at and what they're not good at, and I wish most of the industry had that consensus perspective that you were sharing, because it's a regular part of what I do to try to help people understand why EMRs are not the key to learning health systems. They are absolutely a pivotal part of a learning health system, but they're really not the key to a learning health system. One of the things I've been talking about more over the past couple of years is this idea of healthcare evolving to be what we think of as a high-performance industry. And the things on the right-hand side of this slide are some of the characteristics that have been talked about as being attributes of what a high-performance healthcare system probably needs to look like. Things like that it needs to be decision-biased. It needs to be more focused on real-time decision-making. It needs to be process-driven and closed-loop. And we'll cover a couple of these things in a minute. What I would say to you is that I don't think EMRs in and of themselves are necessarily well positioned to address these things. They are really well suited to do the things that that Nick was highlighting that they do. But in trying to move us towards this new model of more of a learning kind of environment, that environment is going to be much more closely related to high performance kinds of organizations than what EMRs are necessarily set up to do. So let's talk a little bit about what we're often missing in that conversation. So I work at the UNC Health Care system. If you're unfamiliar with that, we are a statewide $4 billion healthcare system, academic medical center in Chapel Hill, variety of community hospitals spread across the state of North Carolina. And so we have this really interesting blending of needs between what you think of as a research-oriented environment characteristic of an academic medical center and a lot of rural patients around the state. We're also a safety net organization. And so these things kind of come together and create a really interesting environment for us to think about how to evolve and change healthcare. As an academic medical center, one of the things that we're really, really good at is thinking about research. We have a massive infrastructure in place at UNC Chapel Hill for research. It's a core component of what we do. And we couple that with a fairly strong focus in quality improvement within our hospitals, and as we're developing clinically integrated networks and other care delivery models, quality improvement is something that's a fairly tight fabric for what we're doing. I think part of where we're trying to move from a data sciences and an analytics perspective now is to kind of recognize that there is this other end of the spectrum as well, this idea that even though we have all of these tools that come from a place of controlled or semi-controlled observations, we also now, because we're collecting all this information electronically, we have the ability also to look from uncontrolled or real-world experiences back into our environments and try to draw some insights and some understandings around what are the opportunities to decrease cost, improve patient satisfaction, get better at putting the right treatment to the right patient at the right time, that these kinds of observations really lend themselves to be able to do. For some organizations, that shift from thinking of the world really as being this science-driven, clinical research, controlled study-oriented view of the world, that shift over to, well, it's actually okay to look at things purely observationally, and when it is okay to know that something tends to be true whether you know why it's true or not. That shift is actually a cultural shift. That's not a technological shift. There's nothing in my analytics portfolio that insists that I only do one or the other. But my ability to influence change in the organization is it's a cultural change of expanding the comfort zone of how people are consuming information and the way that they're thinking about making decisions. So I wanted to give you a quick example of this kind of environment that I'm talking about, and in particular to think about those features and those attributes of learning health systems and high-performing organizations, how those come into play in the kinds of scenarios that we're talking about. So this picture that I have here is an example of a population health-oriented model that we have developed at UNC. And the way to interpret this is that the right-hand side of this picture, the assess phase, is where you are trying to evaluate a particular population health opportunity to understand what the design characteristics of that program might need to look like. So who are the patients? What are their risk segments? How are they stratified? Where are they getting care? What does their utilization look like? So there's this whole assessment phase on the right-hand side. And then once that program is designed, on the right-hand side is where we're actually running and operating that program, and we're trying to monitor and collect data about what's actually happening with these patients. So if we, during the assessment phase, said we think utilization looks like X, is that actually what utilization looks like? Or if we think that their clinical risk profiles look like Y, is that what we actually see in the real world as these patients are receiving care with us? And the beauty of the model here is that the right-hand side is connected to the left-hand side. So as opposed to the way we would have done this kind of work 5-10 years ago, where the assessment phase was a group of people that sat in a room and created a project and did some analysis, and then that got shelved, and then there's a whole different group of people over here that were responsible for running the program and have no idea what the assumptions were that were being used in the design of this. We're trying to create now a model where those two sides are all the same, and we're able to refine our our assumptions and our models over time to gain a better level of insight. So you can begin to see here, this begins to feed some of those attributes that I was talking about earlier. This is very iterative. This is a closed loop model. All of those things that really characterize from a design perspective a higher level of functionality and engineering we're trying to institute within a data sciences framework. And we think this concept is really fundamental to beginning to recharacterize healthcare as a learning system and not just a delivery system. So let me talk a little bit about what learning then looks like. So as an undergraduate, ironically enough, my degree was in psychology and chemistry, and so it's odd that I find myself many, many years later trying to recall all of the things that Dr. Geller and others were telling me around the psychology of learning. But suffice it to say that there's a very rich set of research that's many decades long in psychology around what constitutes learning, how do people learn, what are the attributes that drive learning, and I'm not going to try to rehash all that for you today, but what I tried to do in this slide is just give you a few of the key characteristics and dimensions that people think about when they're thinking about learning. So first of all, there's different types of learning, right? So you can learn knowledge and skills and behaviors. Values can actually be learned. Even preferences can be learned. And those things tend to be learned through facts and experiences that are really quite data rich in terms of the things that the individual is experiencing. And at the heart of this learning experience is really this context that I was talking about earlier, which is very process driven. Learning is a very iterative kind of experience for most people. Excuse me, I'm at an interesting place today in that, as you may be able to tell from my hair, I am more of a musician than a sports enthusiast. And yet I'm standing up here today, and tonight UNC will be playing in this national small event that many of you are probably familiar with. This is Carolina Blue, and it is intentional, if that means anything to you. But what's been interesting to me in watching the UNC basketball team go through the process of getting to this point is how much learning and practice they as a team had to go through to get to where they are right now. And they exhibit many of these factors that we're talking about here. They run plays that I don't care how many times you scripted these plays, you'd never be able to get a play to execute that way because it's not so much about the moves, it's about the context and the iteration and the play and them getting to a place that they know each other so well that they can do things that almost look magical at times on the court. That's the kind of rich learning experience that I think we need to be moving towards in healthcare. So let me give you a model of what I think that looks like. In 1967, Posner and a couple of other guys were looking at learning, and ironically enough, they were looking at learning in athletes. And they came up with this three-phase model of learning. So at the lowest phase is what they call the cognitive phase. And the cognitive phase is the phase that I never got out of when I was trying to learn to play basketball. The cognitive phase is the phase where you're standing on the court and people are running all around, and you don't know what dribbling is, and you don't know what the foul line is, and everything feels awkward. You're trying to learn the rules, you're trying to learn the steps. I did take up martial arts as some form of physical activity for myself, and I remember the early days of being on the mat and just realizing the sheer volume of the number of moves and stances and different iterations of forms. It just felt completely overwhelming. So the cognitive phase is in that early drinking from the fire hose, right? From that, if you graduate from that, and I never made it out in basketball, I did make it out in martial arts, but if you graduate from that, you get into the associative phase. And in the associative phase, you're taking those concepts and you're understanding how they fit together. You understand how to exercise those concepts together. So in martial arts, for example, Once I got past what are the basic stances, I could begin to see how particular stances and how particular forms applied in different settings. I still wasn't necessarily proficient at it, but I had a much greater appreciation of what I needed to practice and how I needed to practice to really get some learning that would allow me to go to the next level of performance. And then the third phase, the autonomous phase, is where it all comes together at the end. This is where the UNC basketball team is. I don't know if I ever got to the autonomous phase or not. I saw a glimpse of it once or twice, moments of greatness, I think we were talking about earlier. But if you think about where all these things come to, I think that there's a very logical maturity model that we can begin to think about healthcare going through. Some of you may recognize this general trajectory as being similar to the kinds of analytical maturity models that I've spoken about before. This is just more of a learning view of the same kind of concept that as a healthcare system, I think we can expect to go through this same kind of continuum where today I think we're fairly low. I don't know if we're only in the cognitive phase, but we're certainly, for example, in the phase of looking at metrics purely from the perspective of generating lots and lots of data and creating lots of buckets to look at things. And that's interesting and that's necessary. You can't get to the top without going through that. But hopefully we're going to be able to navigate this process a little more quickly over time. I'll give you a few examples to think about. I'm not going to walk through all three of these, but I just mentioned the last one, this idea of quality. So a traditional way of thinking about quality metrics is let's figure out what are the metrics that we're going to be assessed against, and then let's track those in dashboards. And that's great, except if you go out and you look at how many metrics a system like UNC could be held accountable for in our contracts, it's more than 9,000. So probably not useful to think about that from a dashboard perspective, right? You can't make enough dashboards to track that many things, and even if you could, you're not going to get any behavioral change around that. So thinking about quality metrics beyond that early phase one, that data collection or that cognitive phase, thinking of it then as a maturity model that's a part of a learning health system, how do I understand what metrics are actually important for my patients, for my healthcare system in my geography, giving our sets of services? How do I begin to then translate that into something that's really meaningful for my organization? What are the factors that are driving changes in the quality metrics that are most important to me? And then how can I begin to manipulate those factors to optimize the performance to best influence those metrics? So I think that kind of translation is where we're trying to get to. It's certainly part of what I'm trying to do at UNC is help us go through that maturity process. As I said earlier, part of this is a cultural challenge, and I love this study. It's a wonderful example. If you've ever had the experience, as I have had, and I consider myself a fairly decent technologist, if you've ever had the experience of your kid taking up a device, a piece of technology, and just being naturally more fluent with it than you as an adult are, even though you understand 10 times more about the technology than the child does, this is a great study that explains why that's the case. And having read the study, it gave me a great laugh to think about the number of times that I've had some kind of experience with the user interface, and I have pushed the same button 17 times expecting it to do what it did not do after I pushed it the first time. And it's because of this issue here that adults tend to stick to the first most obvious potential solution, even if it's ineffective. That's the way we approach the world. We have already generalized the behaviors of the world around us, and so we tend to try and want to interact with it that way, whether it actually works or not. Children, on the other hand, are not bound by those cognitive experiences and those conditions. They're much more flexible, fluid thinkers, and so their ability to work with practice-based evidence as opposed to evidence-based practice is a little stronger than ours. And we just have to think about how do we begin as healthcare systems and as constituents in the industry, how do we begin to challenge our assumptions around what works, and how do we support this kind of more fluid and flexible thinking? So I want to move towards wrapping up here and just mention a couple of other things. So part of my job at UNC is to develop a new organization that's responsible for prosecuting this mission that I'm laying out for you today. And so I wanted to give you some insights around the way that we're thinking about doing this operationally. Like, how structurally do you begin to take this on? So the first thing that we have tried to do is institute a new governance model that really helps us as a system to better think about and prioritize where are we making investments in this, because the scope is this large, right? It's huge. And what we need to be able to do is kind of whittle down into what are the big blocks, what are the big things that we need to be able to accomplish over the next couple of years, and how do we then stand up the right resources to do that, probably at the expense of other things that are not maybe as important. So we have some hard decisions to make. So there's a new shared governance model in place. The second thing that we're doing, and this goes back to some of Nick's comments as well, is we are implementing what I call a proper engineering function. It's really interesting in healthcare. So many of us that have come into healthcare did not come into healthcare with any kind of background in how to build reusable, high quality, high resilient types of capabilities and assets. But much of what we're talking about here is, I don't want to define 27 different times what a diabetic patient is. I need to define it once, and I need it to serve the needs of the system. So thinking about introducing proper engineering disciplines, which include agile development principles, which include the concepts of what commercial software providers would call product managers, people who own the capability roadmap of particular aspects of our business, is a key part of what we're looking to do here. The third is recognizing that no matter how successful we are in building things, none of this is going to work if we don't have a very strong focus on enabling our end users, who are the clinicians, the nurses, the patients that are actually in the healthcare system. So as much as I like to think about this engineering thing as looking like the commercial world, there's a really big difference in that the way this all comes together at the end of the day has nothing to do with the way I package and market this. It has to do with the way people are able to work with it. And so creating a function that's specifically focused on that is pretty important. And a key component of that, particularly for a large system like ours, is how are we addressing the communication and the community development around being able to do this? Because that's really where the cultural transformation is going to happen. It's not going to happen from some top-down mandate of here are the new analytical models. It's not going to happen because I'm particularly good at going out and talking to people about the value of a particular risk model. It's going to happen because people see a different level of value and get a different kind of experience, as Adrian was alluding to, than what they've had before. So these are the four pillars of the way that we're looking to do it internally. So as I go to transition out of this, I would just highlight for you that I'm not sure that we're keeping pace with what the original IOM timetable was looking like. I don't know if you guys feel like you're going to hit this by 2020. I do not feel confident around that myself. And I do think part of this is, as an industry, we need to turn up the gas on this. I mean, it's one thing to think about all these interesting quality metrics of capturing all the things that happened 3, 6, 9 months ago. But at some point, we need to effect the transition of what is going to be happening in the next 3 to 6, 9 months, and how do we optimize that for our patients. So in summary, how do you know if you're on a learning health system path? I think, do you have a roadmap for your own learning health system? Does your roadmap account for these kinds of good learning practices, things like timeliness and contextualization? Are your builders actually building high-performance kinds of designs? And are there explicit owners for each of the organizational competencies that I was just talking about, the pillars that are going to be responsible for kind of making this a reality? And finally, are you making room as a part of that for this idea that practice-based evidence is also really good? Evidence-based practice is great, but practice-based evidence is also really a key component of this as well. So I'll stop there and take any questions you might have.